Thank you so much for the introduction. Again, my name is Jamie Doyle. I'm a program director at the National Center for Advancing Translational Sciences, or NCATS, at the National Institutes of Health. I'm also a project scientist for an NIH-funded program called the Collaboration for Down Syndrome Progress, which I'll talk about in a little bit in a few slides below. In my personal life, I serve on the board of directors for Compass Inc. Maryland, which is a non-for-profit that runs community living group homes for individuals with intellectual and developmental disabilities. I also am the past vice chair of the Montgomery County Intellectual and Developmental Disabilities Commission, and I also have two kids with autism. Oh, fine. I can't forget this. So I also really want to thank DSA Maryland and Brittany Preston specifically for inviting us to speak with you today. I know it's a tremendous lift in terms of scheduling, so thank you so much. So my role will be mostly as a facilitator. I'll introduce Dr. Spinazzi as well. At the end of the presentation, what I'll do is I'll include a QR code. So if you have any questions during the course of the presentations, or if afterwards you go, I sat there and thought about, I had this question that I didn't quite get to ask, just go ahead and scan the QR code and it'll shoot you over to an inbox at NIH, and we'll be sure to get your question addressed. Okay, let's get started. Many of you are aware of the National Institutes of Health. It's right here in our backyard in Montgomery County, Maryland, based in Bethesda. We are the world's largest funder of biomedical research. And what not many people know is about 90% of our funds actually go to universities and research institutions around the world to support research studies. Our director is Dr. Jay Bhattacharya, who's pictured right here. He became NIH in 2025, and he comes to us from Stanford. So you'll hear a lot about the Include project. It's alphabet soup, usually in the government. This Include project is no different. It stands for the investigation of co-occurring conditions across the lifespan to understand Down syndrome. And this was a congressionally mandated initiative that was launched in 2018 that focuses on the critical health and quality of life needs of individuals with Down syndrome. The Include project has three goals. The first, of course, is to support research that affects conditions in the Down syndrome population, also co-occurring conditions such as Alzheimer's disease, autism, which we'll talk about today, celiac disease, and more. We also have a big focus on career development. So the long-term sustainability of all these NIH investments really relies on the next generation of researchers that continue the research. So we also have a second focus on career development. And finally, the most important part of this research is that we engage communities just like you, parents, families, throughout the whole research process, not only to ensure that the results are meaningful for individuals with Down syndrome and their families, but that these benefits really are disseminated to everyone. So this is the kind of just a broader look at NIH funding for Down syndrome research over time. So if you look at just the yellow shaded area, this is just support for Down syndrome research without sort of a dedicated funding line for Down syndrome. That's part of the Include project. What you'll notice is that before 2018, before this congressional mandate, the support for Down syndrome research was around $20 to $30 million. But really after 2018, because this is a dedicated funding line, research just exploded. So we're at about a little over $100 million that is dedicated to research on Down syndrome. And I want to just give a shout out to all the families who made this possible. This is a direct result of your advocacy, going to the Hill, talking to your congressman, and this research continues because of your advocacy. And we've had a lot of wins. So far, we've supported over 400 research projects, well over 450 publications, 26 Down syndrome specific clinical trials. We've supported many trainees, and thanks to people like Linda, we're also out there in community. So we're really big on community engagement and outreach events, in part because we have such excellent staff who are also committed to community engagement. So I mentioned earlier in my introduction that I'm project scientist for the Collaboration for Down Syndrome Progress. And so I thought I would take a moment to describe that in a little bit more detail. So the CDP is a $32 million investment to follow a cohort of individuals with Down syndrome at various ages throughout the lifespan. That means following infants through adulthood. That means following adolescents through when they start to age, to really understand the natural progression and course of Down syndrome. So when do these co-occurring conditions tend to start? What kind of treatments and interventions are the most effective at what ages, to better understand how we can improve the quality of life of individuals with Down syndrome, but also of the general population. And the great news is that we are enrolling families. And so if you're interested in being a participant in this study, you can go ahead and scan the QR code. Kennedy Krieger is one of our recruiting sites. And so we can get you in touch with them if you're interested. If you're interested in other types of Down syndrome related research and resources, the Include Project also funds DS Connect, which is a Down syndrome registry. But beyond just a registry, I get a lot of questions about, hey, what kind of clinical research studies am I potentially eligible for? And this is, instead of swimming through all the different conditions out in clinicaltrials.gov, this really consolidates a lot of the possible studies you can participate in one particular site. There's also resources. So if you're interested in making better or more informed decisions with your doctor, with your child's doctor, this actually also consolidates resources that you may find helpful. And finally, if you want to learn more about the Include project, again, this is the QR code. You'll see it now, but also showed at the end, just in case you have any questions following the presentation. So that's it from me. And I wanted to go ahead and introduce Dr. Noemi Spinazzi, and I'll do that while she's getting her slides up. So Dr. Spinazzi is a primary care pediatrician and director of the Down Syndrome Center of Excellence at Children's Specialized Hospital, and I'll have to in Hamilton, New Jersey. She has more than a decade of clinical experience caring for children with complex medical needs and developmental disabilities. She has earned her medical degree from the University of Pennsylvania. I also earned my PhD from the University of Pennsylvania and did my postdoc in the School of Medicine, so we have that shared experience. She previously served as medical director of Charlie's Clinic at the UCSF Benioff Children's Hospital, where she founded and built a comprehensive Down syndrome program from the ground up. Her work integrated anti-ableist medical education, innovative research, inclusive community engagement, and state-of-the-art clinical care, establishing a model for multidisciplinary family-centered care. I also wanted to mention that Dr. Spinazzi is involved in an Include-funded project titled Autism in Young Children with Down Syndrome, with collaborators from the University of Colorado and Harvard Medical School. Take it away, Dr. Spinazzi.
Thank you. That was a very, very kind introduction. All right, everybody. Hopefully you're ready. You're eating your dinner, and I'm gonna be your dinner show as I talk to you about autism in our loved ones with Down syndrome. As Dr. Doyle just shared, one of my disclosures is that I am part of a research team that focuses on describing early development in children with Down syndrome and among other things, the early predictors of a diagnosis of autism, and that is NIH funded. I'm also on the board of the National Down Syndrome Congress. In this talk, I will use person first language. And I just want to acknowledge that we're talking about two communities that may have different preferences as far as language. Of course, in our Down syndrome community, we prefer talking about people with Down syndrome. The autistic community is a little split. With a lot of self advocates saying, please describe me as autistic, as being autistic is an adjective that should go with the description of how I experience life. Um, and when we generally talk about people with Down syndrome and autism, we say people with Down syndrome and autism, although I may describe someone as being autistic. So I'll use that language interchangeably while using person first language when referring to Down syndrome. I used abbreviation in my slides. And if you have any feedback about the language I use, please let me know. I think words are so powerful and need to be healing always. So please let me know if I need to improve this. And then, yes, I want to start by giving a shout out to this project that has been the joy of my life, funded by Include. It's called Project Capabilities, and our goals are many, include to describe how young children with Down syndrome develop, including their social communication and play, understand how their medical history may impact their development, identify what may be early predictors of a later diagnosis of autism, and hopefully, with this work, also develop improved screening and diagnostic tools that are helpful for our people with Down syndrome. Because we know that all the tools we have available were developed not with people with Down syndrome, and there may be some diagnostic confusion. And also, the passion of my life, hopefully to create lots of material for advocacy so that families don't have to jump through hoops of fire to get what is necessary for their children to thrive. So let's start from the very basics because I think this is important. What is Down syndrome? It is a genetic syndrome. It is brought upon by having an extra copy of the 21st chromosome in some or all our cells. It is typically diagnosed before or soon after birth. We can get clues from facial and body features, but the diagnosis is made with a blood test. It is fairly unequivocal. Yes, no, the blood test is going to tell you. There's little subjectivity to it. On the other hand, autism is a neurodevelopmental difference, and we don't have a clear cause for what causes autism, although we do know that it's not vaccines. It is typically diagnosed not at birth, but rather in early to mid childhood when we would expect to see some specific social and communication skills to develop, and we instead begin to notice a different way of those things developing. And there is no blood test, no MRI, no EEG, no X-ray that can diagnose autism. The diagnosis is made clinically through observation, through history. So there's some degree of subjectivity to it, and that subjectivity can bite us in the butt sometimes, especially if we're not super familiar with how autism can present. The main core differences, features of autism are challenges with communication, especially communication for the purpose of a social exchange, difficulties with understanding and sustaining, keeping going a social interaction, some restrictive and repetitive patterns of both behaviors and interests, and a core feature that appears a little later in the definition, but I think is so important to understand. Differences in how we take in and process what comes in through our senses in a way that can deeply impact a person's experience. So, can the two things happen together? Yes. All right, you can leave now. No, just kidding. That was, but yes, definitely. And it is so very important to understand when someone has both because it helps us understand how to best support them, how to best support their learning and their independence. How common is it? Quite common, actually. Uh, Estimates in the literature range anywhere from 4 to 41%. I like this study that's called a meta-analysis that takes a lot of studies and kind of tries to find a reasonable number. And this suggests that 16 to 18%, that's about 1 in 7 kids with Down syndrome, is also autistic. That's a lot. That's more than 1 in 31 in what we call the quote unquote general population in the United States, according to 2025 data. So it is more common in our loved ones with Down syndrome than it is in those without Down syndrome. Like in what we call the general population, it appears to be more common in males than it is in sex assigned at birth females, with several studies noticing a much higher percentage in boys than in girls. Any connection with medical history? The strongest association we have found over and over is having a history of infantile spasm. This is something that we've been able to find in multiple studies. So it doesn't mean that every child who has infantile spasms is going to develop autism, and those children with a history of infantile spasms have much higher odds of developing, of being diagnosed with autism later on, and that should be a population that we monitor extra carefully. It appears that those with Down syndrome plus autism are more likely to have seizures, including infantile spasms, constipation, and reflux, even more commonly than in those with Down syndrome only, which are pretty common, behavioral feeding difficulties, and, interestingly, scoliosis. Now, this is in publication, but this came from looking at kids followed in Boston, a big, big center for care for kids with Down syndrome. And we just took a look at kids followed in Denver, Colorado, another really big clinic. And some of these things hold, like the feeding challenges, the scoliosis, and the seizures. While some may not show didn't quite come back the same, like constipation and reflux. So definitely the jury is still out. And this information comes from people looking back and thinking back to patients and medical records. So that's the strength of the study capabilities, is that we are following these children from when they're really little, and we're actually following things as they unfold, including their medical stories. And so I'm really excited for what's going to come out of CAPE and its sister study called Birthday Study that's also collecting some blood samples. So stay tuned for more. And one more piece about history is that it is more likely to have a story of having lost some skills, including some language skills and some developmental skills, compared to those kids who only have a diagnosis of Down syndrome. This is how some kids with autism in the quote unquote general population present. And what we are noticing is that when we look at those with Down syndrome and autism, it may happen a little bit later. And what I always say is whenever there's a loss or regression in skills, we gotta put our medical hats first and really think about any medical reason for these changes, like new seizures, how's the thyroid, any new hearing or vision loss, and really look hard for a modifiable reason for this, a treatable thing, before coming to a diagnosis of autism. And this is the one time I will mention Down syndrome regression disorder. And this is different from a regression of skills in early childhood as a presentation of autism. DSRD is what appears to be a neuropsychiatric condition with some autoimmune components to it and some psychiatric components to it that happens in late adolescence and young adulthood, and really much later than what we're talking about here. So, how do kids with Down syndrome present when they also have autism? I will walk us through some of the signs and symptoms, and you will see references at the bottom of my slides to share with you that what I'm presenting to you, comes from both the research and the medical literature, and also what we observe clinically. So it will be a blend of both things. One thing we see is what we call stimming. Some other terms you may see are called stereotypies or repetitive behaviors. These can be many different things. It can be hand flapping, twirling objects, tapping items, rocking, head banging. It may not appear to have an obvious purpose, although I like to remind everyone that every behavior has some purpose. We just might not understand what it is. And whoops. Um, what I want to make sure we understand is that it can be a common thing that families notice, but it is not unique to Down syndrome plus autism. Many kids with Down syndrome only will have some type of stim. They may come home and spin a little bit in place, or may twirl their favorite little thing, or wave their favorite spoon in front of them. What makes the stimming in those with Down syndrome plus autism different is how much they do it, how there's more types of stims. They tend to be more complex, and most importantly, it is harder to redirect them away from the stim. So if I have a friend with Down syndrome only who's home and is tired or is bored and is stimming a little, and then I go, come on, let's go play. Typically, they'll drop the stim and join me in a social interaction versus someone with a dual diagnosis may be perfectly content in the stim and have a harder time being redirected away. Another thing that we may notice are differences in how we play. Now, what's really important to think about here is what we call developmental age. And so remembering that how kids play changes as their brain grows and their brain develops and their skills grow, right? So I never expect a child who's developmentally at like 6 or 9 months of age to play the same way as a child who's 3 or 4 years of age, right? Their play is expected to change. And when we take that into account and when we look at someone in the context of where they are developmentally, what we see in those who also have autism is a lot less of what we call pretend play. The this is the dolly and I'm gonna pretend to feed it and I'm gonna pretend to comfort it and now I'm gonna put it to sleep and we may see it if it's been really practiced. So if someone's been teaching someone how to feed their dolly over and over, I might still see it in someone who's autistic. But then if I change it up a bit and I say, well, now the baby's dirty, let's change the diaper, they might get a little stuck and still really feel like doing the thing that they've learned to do in therapy. We may see things that we see commonly in kids who are autistic, like lining up toys by color or shape, or sorting them, or visually inspecting them more than playing with them, or maybe inspecting them with their mouths or throwing them instead of playing with them functionally. They may have a harder time with social games like peekaboo or hide and seek. They may really love playing with the same toy in the same way over and over. And again, we are continuing to think about not none of these things in isolation means that your child is autistic. I'm just describing some of these things as my little clues, like I'm Sherlock Holmes and I'm trying to understand, does someone have another diagnosis besides that, having Down syndrome? Another thing we may see is some challenges with social skills. And this is where I say that a lot of my kids with Down syndrome plus autism will still greet me with a smile and will still be very ready to give me a hug and may have some eye contact with me. It just is a little less sustained. I feel like I need to sweat a little bit more to sustain that social interaction. As opposed to with someone with Down syndrome only. And what I really pay attention to is how are we doing with what we call shared attention? How often is the child trying to get me to look at them or get their parent to look at them or for me or their parent to look at something else that's interesting? One of my favorite questions to ask is, if your child sees a puppy in the street or a plane in the sky, what do they do? Do they point to it and look at you to make sure that you see it too? Or do they just get excited and clap, but not necessarily call your attention to it? This can also look like what we would call inappropriate social overtures to call attention. So instead of going up to you and saying, hi, what's your name? They might smack me because that's going to get them there to me and give them my attention some way or another. and really a lot of challenges with the imitation, that back and forth, that is actually really, really important for learning. And this is one of the reasons why I always say it is important to understand if someone is autistic, because I can then work on the imitation as its own goal for development, as opposed to assuming that that skill is there and then teaching, assuming that those imitation skills are there. Hopefully that makes sense. Now, this is a tough one because learning how to communicate is hard for a lot of people with Down syndrome. I, the reason I love working with people with Down syndrome is because they inspire me every day. Because no matter how hard I think something is, I know that someone with Down syndrome is working even harder than me to learn something and to overcome their obstacle. And so I know how hard it is for kids with Down syndrome who are born with lower muscle tone and with a smaller mouth and with challenges with kind of organizing the way they move their tongue to learn to talk. That's why signing can be so helpful. That's why other ways of communicating can be so helpful. And when I look at those kids who have Down syndrome and autism, those challenges feel even more pronounced. It may appear even harder for kids to understand, not just express themselves. With families telling me that they understand what instructions some of the time when they want to. Um, and that they may be inconsistent with following a direction that is familiar and that they have understood for a long time. They may tell me that they learned a word and they were using it for a little bit and then they lose it, which is not super common for kids with Down syndrome. Once they mastered a word, they are celebrating it and using it as much as possible. They're less likely to communicate using phrases as opposed to single word sentences, and generally tend to acquire those communication skills later. And that's when we're talking about mouth words. What we also see is challenges with the social communication. So I love to ask what words kids are saying, and I would expect that very social words like mom, like hi and bye are coming on early on. And so when those are not the first words we say, and instead some less common word might appear, like cow, before bye bye, that I pay attention to that because there is a social communication development that I would be expecting that I'm noticing may be delayed. The language also often feels less spontaneous. Those kids with Down syndrome plus autism who are acquiring words, they're often showing them to us when prompted. Say mama, mama. But then they want mama's attention and they're smacking her, or they're just standing in front of her and whining instead of saying mama. Or same with eat or milk. If you say eat, they might be able to sign milk or say eat, sorry. But then when it's time to eat, they might just go to the fridge, stand in front of the fridge and whine until someone notices that they're there, right? If you have mastered a word, it would be expected that you're using it for the purpose of communication and not just for labeling or to prompt.
Dr.
And what we may,
I'm sorry
yes,
to
and then what we may hear is something called echolalia. So you say a word and then like, do you want to eat? Eat. Oh, yes, we're having meat. Meat. Do you want to have ice cream? Ice cream. That's called echolalia, where you're repeating the last word that someone said. And that's immediate echolalia, but we also may hear what's called delayed echolalia. And that's someone, this is why I have my good friend here, who loved little scripts like Arby's, we have the meats. And Arby's, we have the meats meant yes to him. But it was clearly him repeating a piece of a commercial in a delayed echolalia way. The other one was bologna sandwich, but it wasn't yes. And that's an unusual way of using language and an unusual way of using language for social communication. And kudos to him for trying so hard. Now, what I'm going to show you here is someone with Down syndrome who does not have autism. this child does not have autism. And I want to show you this video. It's short because I want you to notice all of these ways of communicating that are not words. I want you to notice how he shifts where he looks based on who's talking to him, how he moves where he's signing based on who he's talking to, how his face changes as he's communicating different things and feelings, how even though he's not going to say a word, but he's going to make some noises and he's combining them with the gestures that he's using. And then at some point, he says ice cream, and this guy loves ice cream. And I want you to notice the gusto he puts into that sign and how he repairs communication and how he's using other body language to communicate. Because my point here is even if someone is not talking when they have Down syndrome, they're usually using all their other tools to get their point across. Let's look at this together.
How do you say happy? Happy, good job. How do you say mad? How do you say tired? How do you say crybaby? No, how do you say crybaby? Crybaby. ¿Cómo se dice crybaby? ¿Cómo es el chillón? Crybaby.
Understood it.
¿Y tu hermano? How do you say brother? Sister? Ice cream? How do you say ice cream? How do you say cookie? How do you say cracker?
Cracker.
How do you say chip?
La tapadera del galón porque
Waffle.
al gato anda
Bread.
pescando. Bread.
So you saw that, right? You saw that you can still notice some communication differences where when all of that is missing, even in someone who's not talking. And this is what this slide is showing you also, that those children with a dual diagnosis are often pointing less. And when they're pointing, they're usually pointing for what they want more than for what's of interest. Like, ooh, neat, look at that. Overall, fewer gestures. And for those who are using a sign, they're usually using them with a prompt as opposed to spontaneously. Don't get bogged down on these crazy graphs. What I want to show you here is that there's a tool called the communication matrix that speech therapists use in the clinic setting and as well as often in schools. And what we see comparing communication matrices for those with Down syndrome only and Down syndrome plus autism is truly that those with a dual diagnosis tend to have fewer ways of communicating their thoughts, their desires, their needs with whatever mean available. And again, this should light a fire under everyone's butt for how important it is to really support communication in our children with a dual diagnosis. Another thing we see is challenges with sensory processing, just like I told you we see in kids with autism and the quote unquote general population. And again, this is something that we see in general in our loved ones with Down syndrome, but may be more pronounced in those who have autism also. This can look like really big feeding difficulties, but also avoiding creams and lotions or having a really hard time with haircuts and toothbrushing. Maybe having a hard time with loud noises, but maybe just having a hard time in crowds or even not tolerating the happy birthday song or when people laugh unexpectedly. And sometimes we don't quite know what caused it, but we know that our child is having a really hard time and they're having a really hard time being soothed, and we can't quite pinpoint why they're having this hard of a time. We do see differences in eye contact, and though we may see it, it may be less sustained or it may be less communicative. What do I mean by that? If I go like this, no gesture. Don't you want to look over here? Like I'm kind of communicating with you. There is something here. Did you see it? That 3-point gaze, that's really communicative eye contact that we may not see in those with a dual diagnosis. Rather, it might look like a still here, good. And I do definitely see kids who might prefer to peer from the side of their eye, either to look at a person or to look at an object. And I do have to say that sometimes it's hard to tell, and it's only until I'm really up close to the child that I realize you're not looking in my eyes, you're looking at my mouth. You're trying to interpret and figure out what the heck I'm doing and saying because my mouth is moving, and I have a big mouth that moves a lot as opposed to eye contact. But from far away, it can really look like eye contact. And then we do see that those with a dual diagnosis can have a harder time with mood and behavioral challenges, including more aggression towards themselves as well as towards others, some breaking of stuff, some impulsive behavior that is really scary for parents, like running away and general impulsivity. And I will come back to these behavior challenges when we talk about support. And it does appear that kids with a dual diagnosis can take a longer time with developing some of what we call adaptive skills, like toilet training, self-feeding, and this is compared to kids with similar cognitive abilities. So now I've described what you may see, and now you're going to Kennedy Krieger, you're going to DC Children's, you're going and you're looking for an evaluation. What do we know about evaluation? I want you to know that I have shortened this bit because you're not clinicians, and so I want to give you more of what to look for than a whole long blah, blah, blah about all the various evaluation tools. I want to start by saying we need to do better. Me, need to do better. When we started this work, we reached out to families and we said, tell us about your story. At what age did you notice that your child was a little bit different from other kids with Down syndrome? And then at what age were you diagnosed? And the numbers you see there are unacceptable. And then we asked them, who do you talk to? And did they know where to point you? And unfortunately, it was people like me, like primary care doctors, and people like teachers and therapy providers that seem to be the least knowledgeable in the dual diagnosis of Down syndrome and autism. This has been the fire under my butt for all the talks that I've been giving and all the research that I've been involved with since we worked on this study. Let's always start with the basics. Can your child hear well? Can your child see well? And not just do their eyeballs see, but perhaps how is their brain interpreting what the eyeballs are seeing? So therefore considering things like cortical visual impairment. How's the thyroid doing? I had a patient back in Oakland that really looked autistic to me. And there were a lot of other things going on for the family, and we knew that this child had thick fluid in their ears and at least moderate hearing loss, and also they hadn't been able to get him in school. And then all the things happened together. He got his tubes in, his hearing normalized, he got into school 6 months later. He didn't look autistic anymore. So again, this is why it's so important to know to do the basics before or alongside with pursuing evaluations for autism, because there can be things that are absolutely addressable that can explain some of these challenges. How early can you tell? I'm jazzing you up and you're here going like, I want to know as soon as possible. I think that this is where the work of Kate comes in because we have a couple of studies looking at using autism assessment tools in really young kids with Down syndrome. And the bottom line is that young kids with Down syndrome are going to have elevated scores in these tests because of the developmental delays that we expect in this young age, especially around communication, and that these scores may have more to do with their developmental age than with the true presence or absence of autism. So, for example, we have this screening tool. It's called the MCHAT, and every child should be given an MCHAT between 18 to 24 months. And it's a very quick and simple tool. It's 20 questions. It's freely available. There's really no reason for pediatricians to give it to every child. And what we know is that when we give the MCHAT to older kids with Down syndrome, who are between like up to 5 or 6 years old, whose developmental age is at minimum 18 to 24 months, it's a pretty good tool. It's asking the right questions. I want to mention something called the ADOS. You may hear about this. Those of you who have a child with autism in the audience may have seen the study be done. And the ADOS is like a semi-structured assessment with lots of toys. And really what it is a series of like little tricks that should prompt a social response. And what the examiner is noticing is when that response doesn't appear as expected. So, for example, there's a piece of the ADOS where it's just like calling the child's name. There's a piece of the ADOS where you go, Johnny, look, and you see if the child follows a point. There's a part of the ADOS that I use in my clinic visits all the time where you're just a meanie and the child is having fun and then you block their play and you see what they do. Because a more typical response would be to look at you and be like, what the hell? Instead, what a lot of kids with autism might do is maybe just get frustrated and walk away, or maybe just like work really hard to move my hand and never really look up to be like, what the hell, when I don't move my hand. We do have some data that shows that the ADOS can be helpful in recognizing autism in children with Down syndrome, in children with Down syndrome who have severe intellectual disability. And I mention this because oftentimes what I see is that I send someone to an external psychologist because I'm concerned about autism, and they come back with, nope, they just have a global developmental delay. But I'm like, no, wait. But on top of that global developmental delay, they have all of these other bits and pieces. Please do the test. So I want to show you this so that you know that the ADOS can be helpful, but it's not perfect. In fact, no one tool is perfect. That is why we have studies like capabilities, so that we can hopefully perfect and improve these tools so that they can be so much more tailored for our loved ones with Down syndrome. For now, look out for an assessment that has more than one tool, that has an interview of the caregivers, some information from the school, some direct observation, and also some assessment of of all of the signs and symptoms that I just showed you. Seems obvious enough, but I gotta tell you, I had patients who had phone interviews for 30 minutes. And that was their autism assessment. And so I tried to warn families that it should be more than that. And if that's what you got, then that wasn't a real autism assessment, and it's okay to pursue more. So in the time that we have left, and I'm being cautious of the fact that I'm running out of time, I want to talk about how to support our loved ones with a dual diagnosis. And I always like to start with what are we working on? Because if we know what we're working on, then we can think about the things that can help. So of course we want to work on communication. We want to work on shared attention, paying attention to the same thing, maybe the thing the grown-up, want you to pay attention to, so we can learn this thing together. We want to improve flexibility, especially with transitions and changes in routine, because that can be really tricky for some of our loved ones with a dual diagnosis. We definitely want to address behavioral challenges. We want to support independence with daily living skills. We want to support the sensory stuff because that stuff is hard for the kids. And of course, we want to promote safety. The way I like to think of it is the child in the middle always, and then thinking about all of these little targets, and then what can help with each of these things, and then how can we implement them. So what's in our toolkit? We have lots of therapies like applied behavioral analysis. We can have PT, OT, speech therapy. We can have an optimized school program that takes into account the autism diagnosis. We can think about lots of different communication interventions. We can provide training to families and parents to support behavior, especially when ABA is not available, or if it's just not feasible with all of the other things that we're doing. And then we really want to give respite and support to parents because this can be stressful, and considering medication as well. So before we go to the therapies that require scheduling and resources and all of that, let's talk about the things that everyone on this call can begin doing today. One, visual schedules. When you increase predictability in life, you decrease anxiety and increase independence. It is helpful to have these things be visual because visual processing in many kids with Down syndrome and in many kids with autism is strong and stronger than how we process information auditorily. And it can be available for reference whenever I need it. We can take that idea of visual schedules and apply it to individual tasks, what we would call task strips. So for a task like using the potty, when we really stop to think about it, there's a lot of steps to using the potty. We can break those down and make them visual so we can have a visual scaffold for a task. Social stories are stories where the protagonist is the child, and what we are describing is the expected behavior, the desired behavior in a situation. We do not include the things we don't want the child to do. We only describe what we want the child to do. Johnny is gonna go to the doctor's office. He's gonna step out of the car. He's gonna walk into the building. He's gonna say hello to the receptionist. He's gonna sit and watch his iPad until the nurse calls. He's gonna sit in the chair. He's gonna let the nurse put the blood pressure cuff on. It's gonna squeeze. It's okay. It will be done soon. He's gonna get the temperature checked, and then he's gonna move to another room where the doctor comes in. Doctor's gonna talk to mommy, then doctor's gonna check heart and mouth and ears, and then we're all done. And we get to go to the car and watch more iPad. Great job, Johnny. Explaining the expected behavior promotes success, and success begets success. We feel good, we feel less anxious when we know how to get it right. More visuals. I showed you some pretty complex visuals. Sometimes we have to start with more simple visuals, like first this, then this. Not, first this, then this. And this can be helpful so that you know that after a non-preferred activity, you get a preferred activity. And you know that that wonderful thing is coming. All I gotta do is get through this little hump first. I'm a big fan of visual timers. Time is a very abstract concept. It is hard for people with Down syndrome to fully understand time. And so having it be a visual thing can be so helpful. And even if you don't have a high-tech communication device, you can have visuals that a child can touch or point to that can support their communication on the go in a way that is super simple and accessible. A shout out to Teresa Understall, who provided a lot of this advice and has written a book on it, as we will talk about in a second. Occupational therapy can be really important. I want to briefly introduce the concept of a sensory diet. A sensory diet has little to do with what we are eating and more to do with the kinds of things we are feeding our sensory system. That means that, for example, if a child tends to crave a lot of deep input and they're hungry for that input and they feed that hunger by bumping into stuff all the time, we might feed that hunger by providing sensory input at specific times in the day so that the child is less likely to snack on it, bumping into stuff, and have that need fulfilled. An occupational therapist can be really helpful in understanding a child's specific sensory needs and develop the sensory diet. Applied behavioral analysis is a therapy based on a science that explains that every behavior has some sort of purpose and that every behavior is more likely to occur when certain things happen before and when certain things happen after that keep the behavior around. And so if we apply that science to understand the purpose of the behavior, the antecedents, the things that are coming before that trigger the behavior, and the consequences, the things that are happening after the behavior that are keeping the behavior around, we can then unlock a plan for how to decrease some of the behaviors we want to see less of and see more of the things we want to see more of. I had a video here of what ABA can look like in someone with a dual diagnosis of Down syndrome and autism. For the sake of time, I will skip it. But what I want to say that I would have shown you in this video is that punishment has no place in ABA. It was used more commonly in old school ABA. And coercion also has no place in ABA. And that recognizing that there's a lot of controversy in the autism community about ABA, I usually I guide families into how to recognize when ABA therapy is being delivered in a high quality way. The child should not dread seeing their ABA therapist. There should be naming of a feeling if a feeling is what we believe is motivating a behavior. And again, there should never be punishment. ABA can look a whole lot like playing, especially for the first several months, especially if we're working on foundational goals like shared attention and imitation. And so having some clear expectations of what ABA can look like is also really important so that families don't get frustrated with what they're seeing. And when ABA is not available, parent training can also be very helpful. And when ABA is available with direct services, parent training should always be a component of the service so that parents can also learn some of these ABA principles and learn to apply them. Speech therapy is essential. And what I want to make sure I say here is we need to make sure that what we're working on makes sense. If we have a child who's just using a few words and they're not using them for a social interaction and is having a really hard time with imitation, it would be insane to work on pronunciation. We would need to work on imitation, on the back and forth, on that shared attention first, and then build vocabulary and then work on how we're pronouncing things. If we're working on the wrong goals and targets, the experience is going to be really frustrating. And again, this is one of those really important reasons why recognizing autism is important, because that allow us to evaluate the presence or absence of those foundational skills. And then, I'm a parent. And I know that I really, above all, want to meet my child's needs. And sometimes, to avoid the meltdowns, that means anticipating those needs or meeting them before she tells me what she needs. But that's not necessarily going to promote communication. And so part of what a good speech therapist would work on is a little bit of sabotage of like putting the things we really want out of reach to create an opportunity for communication, opportunities to model the word before immediately giving it to the child. And communication support can be things like speech therapy to work on the actual communication foundation, and also support around the social communication piece, including interpreting social cues, how to initiate and maintain appropriate communication topics, how to improve on our social skills. And this is this picture of this lovely young lady playing basketball reminds me of the importance of inclusion and the importance of a healthy beyond school life with lots of activities and friends, because that always supports his social development and communication. And I also want to mention that some kids really, really, really struggle with using mouth words. And that is why I'm such a big fan of total communication from really early on, from before I can even tell if someone is autistic or not. Because if I give you all the tools from the beginning, then one, it's going to help me know if there's an additional neurodevelopmental diagnosis present. But regardless, it's going to help the child, because if one way like mouth words doesn't stick, maybe sign language will be just the thing, or maybe an augmentative communication device or a PEX board can be just the thing. And some parents are worried that, boy, if I introduce augmentative communication, will my child ever learn to talk? And frankly, the science shows that it does not slow down the acquisition of verbal communication if that's in the card. In fact, quite the opposite. Having other communication supports is what's going to promote the use of verbal language if that's in the cards for the child. I know I'm running out of time. I have a couple more slides, I promise. I do want to talk about a structured learning environment with predictable scheduling, a physical structure that promotes concentration and reduces overstimulation, and routines and work systems that can make a child feel really, really good and effective in the educational setting. And honestly, this is another reason why it's so important to have awareness about another diagnosis because it requires collaboration with the school team. And IDEA, the beautiful law that gives us special education, one of the pillars is meaningful parental participation. So you parents are an essential part of that educational team and your word means a lot. And so we have to go back to the drawing board. Are the core needs addressed? Is there a behavior plan in place? Is there a sensory plan in place? How are we supporting communication? What accommodations have been most effective? Which communications make no sense? And let's cross them off this IEP because you picked them from a bucket of accommodations, but they really don't apply to my child. What is the classroom setting? Are there some things that are really triggering for the child? I've had some kids who have a really hard time because there's someone else in the classroom that's really having a hard time and is really loud and really agitated and maybe really self-injurious. And that is really part of what's contributing to my patient's behavior. So again, really thinking about the whole setting. And then how are we supporting the child when they're worked up? Are we de-escalating? Or are we kind of five people hovering over the child, all giving verbal instructions in a way that's going to get that child into an even bigger fight or flight state that's not going to be helpful for the child? And let's talk about safety in the classroom because I have a lot of kids who have been found in parking lots, who have been found without supervision, and nobody knows how they got there. And that is really a lot of kids who are big runners, Olympic track runners, need that kind of one-on-one supervision to stay safe. And we sometimes have to lean hard into that advocacy to make that happen. Medication does have a role in supporting some children with Down syndrome plus autism. There are no medications that undo the core symptoms of autism. There is one study looking at cerebral folate levels in children with Down syndrome and children with Down syndrome and autism that show that cerebral folate levels are normal in children with Down syndrome and in children with Down syndrome and autism. So leucovorin really does not have a role at this time in our knowledge in the care of children with Down syndrome plus autism. There are no medications that undo the core signs and symptoms of autism, but there are many medications that can help with some of the behavioral challenges that we can see, including aggression and self-injury and impulsivity and anxiety and sleep. And if we're considering medication, we have to start low and go slow. We know that our loved ones with Down syndrome's brains can be really sensitive to medication, that we might see some unusual side effect. And so this has to be a journey really closely taken with your developmental doctor or your psychiatrist or your pediatrician, if you have a brave one, to monitor for side effects and to have clear goals. What is the medicine treating? If I'm giving you a medicine for impulsivity, I might not expect it to help with sleep. So I'm not going to be surprised if it's not helping your child sleep better. I'm going to be monitoring their impulsivity. And I think we, the clinicians, do a disservice to families when we skip this part of the conversation, understanding what we're treating and what we're targeting. And this is just a list of medicines that we may use and what we may use them for and some of the possible side effects we may see. In the study that got published this Monday, we asked clinicians and providers, what have you found to be most helpful for your patients with a dual diagnosis when it comes to communication, and the responses have been speech therapy, augmentative communication, and ABA. And when we asked them about self-injurious behaviors, they mentioned ABA, psychotropic medication, and parent training. And what they also told us is that once that diagnosis comes in, they give you a slew of referrals, and it's okay to ask your doctors, can you help me prioritize? Because as far as I know, there's still only 24 hours in a day. And then I want to end with a word about support. Because receiving a diagnosis of autism can come with great relief for a lot of caregivers who've been wondering for a long time what else is going on with their child. And also, it comes with a second diagnosis to contend to, and sometimes some amount of grief and coping that has to happen. And it's okay. All of it is okay. All the feelings are okay. And the diagnosis does not change who your child is. It just helps us understand them better. And we know you're stressed. We know you're really stressed. And we want to support you. And what seems to be helpful are things like local support groups. So thank you to the Down Syndrome Association of Maryland, and also DSASD specific support groups and resources. So I want to end by sharing information about the Down Syndrome Autism Connection, which is an online support group that is specific to kids with a dual diagnosis. And then we worked hard with Autism Speaks to have a landing page on Down syndrome and autism. I work closely with NDSS, and as of last month, there's a whole page on Down syndrome and autism on the NDSS website. And then these two books, When Down Syndrome and Autism Intersect, and then a new course by Teresa Unnerstall that has a parent perspective with a great end to that book that has like basically a recipe for how to get through your IEP and how to get through those few months after the diagnosis, and is just, they're both great resources. And with that,